Hello, everyone. Thanks for listening to today's talk. Today, I'll be talking about the prevalence of accessory thyroid tissue detected using 131 iodine SPECT CT imaging, and this is from a single center experience. So, just a brief introduction. Accessory, also known as ectopic thyroid tissue, is a congenital condition caused by disruption to normal thyroid migration, which occurs during embryonic development, resulting in the presence of ectopic thyroid tissue in locations other than the orthotopic thyroid bed, which is located anterolateral to the second to fourth tracheal rings. So ectopic thyroid tissue can be located anywhere, basically from the base of tongue at the foramen cecum to the base of the diaphragm, so basically the neck to the anywhere along the thorax. There are also multiple rarer locations, including the tracheal, submandibular, lateral cervical, etc. But the majority of ectopic thyroid tissue is in the lingual and sublingual location. There's also a subcategory of ectopic thyroid known as dual ectopic thyroid, which is a phenomenon whereby there's the presence of both a normal orthotopic thyroid gland as well as another fully formed second thyroid gland in an ectopic location. This is considered a much rarer form of thyroid ectopia, where 70% of ectopic thyroid cases lacking thyroid tissue is at the orthotopic, lacking thyroid tissue at the orthotopic pretracheal site. Thyroid scintigraphy is considered both highly sensitive and specific in differentiating normal thyroid and ectopic thyroid from tissue swelling of other causes. The utilization of hybrid thyroid scintigraphy with SPECT CT has further allowed accurate localization of ectopic thyroid tissue with increased accuracy. This is because with thyroid scintigraphy we use radioactive iodine, which localizes more sensitively and specifically to thyroid tissue, since it's taken up by thyroid tissue. Compared to using other forms of cross-sectional modality imaging or ultrasound and deciding whether or not that tissue is thyroid tissue. In our study, we retrospectively analyzed the frequency of accessory thyroid tissue in ectopic locations identified in patients who underwent whole-body iodine 131 scans using SPECT CT. So we analyzed about 57 patients who received iodine 131 therapy. All 57 patients had imaging performed between September 2020 and September 2021 following ablation therapy. The scans were performed 48 hours following an ablative dose of I-131. And we used a hybrid SPECT and 16-slice CT scanner. The study protocol involved the generation of planar images, SPECT images, low-dose CT images, and hybrid SPECT CT images, of which we'll show a few later. Both a radiologist and nuclear medicine physician at the institution retrospectively analyzed all 57 studies and identified the presence and locations of all accessory thyroid tissue. In this study, accessory thyroid tissue was defined as any distinct focal area of increased uptake or radioiodine separate from the orthotopic pretracheal thyroid gland. The patient characteristics included in the study are summarized in the following slide. Of the 57 patients included in our study, accessory thyroid tissue was identified in a total of 12 patients. Accessory thyroid tissue was most commonly identified along the thyroglossal duct region, from the thyroid bed to the hyoid bone. Other locations included lingual, location of ectopic thyroid tissue, as well as anterior to the thyroid cartilage and the left inferolateral neck superior to the sternoclavicular joint. So this is a summary table of our results. You can see that most of the patients were female, and 12 patients had evidence of accessory thyroid tissue, of which the most common was in the thyroglossal duct region. So these are a few examples of what we saw. So in figure 1, a 27-year-old woman with papillary thyroid carcinoma was referred in by her endocrinologist for radioiodine ablative therapy, having received a completion thyroidectomy nearly a year prior to therapy. Nearly 4 gigabecquerels of radioactive iodine was administered orally, and a post-ablative scan was performed 3 days later. Planar thyroid scintigrams, both anterior and posterior, demonstrated 2 large focal areas of intense iodine activity at the midline lingual region and at the midline thyroid bed region, which we can see here, or here, as well as up here. We later did, we concurrently performed SPECT CT images, and we can see here the low-dose CT images in the top row, the SPECT images in the middle row, and the SPECT CT images in the bottom row. So A, B, and C, the low-dose CT, so all the images you can see are at the same plane. So the column here from A, D, and G are of the same region. B, E, and H are of the same region. C, F, and I are of the same region. So we can see here from the given provided arrows that there's clear delineation of the ectopic lingual thyroid and the residual thyroid tissue at the pretracheal thyroid bed. We can see that the SPECT CT images precisely localize the exact location of the ectopic lingual thyroid to the midline base of the tongue here. Figure 3 clearly delineates the presence of the normal remnant orthotopic thyroid gland here at the level of the pretracheal region. Figure 4 is of a different patient, a 60-year-old man who was also referred for radioactive iodine ablation therapy, and we can see that the plane images A and B confirmed 2 foci of intense uptake at the thyroid bend and in the lingual region. We can see here better that the SPECT CT more precisely localizes the presence of accessory thyroid tissue to the region of the embryonic thyroid glossal duct region. Here we can see that it's just sort of anterior or along the thyroid cartilage region here. So just a brief discussion on our findings and postulating possible explanations for what we have found. So few studies have been published so far in the existing literature examining the prevalence of ectopic thyroid tissue. The true prevalence of ectopic thyroid tissue is unknown. A commonly cited estimated prevalence of thyroid ectopia amongst existing literature has been reported to be between 1 in 100,000 to 300,000 persons, or 1 in 4,000 to 8,000 persons with thyroid disease, based on a study in 1977. more recent studies have reported a prevalence of approximately 1 to 2%. The diagnostic modalities employed by these studies, which have been published to identify ectopic thyroid glands, consist of a combination of serology, ultrasound imaging, as well as cross-sectional imaging, including CT and MRIs, as well as more invasive measures such as fine needle aspiration cytology and biopsy. However, our study suggests that ectopic thyroid tissue is much more common than previously thought, with up to 21% of the study population having detectable thyroid tissue separate from the pretracheal thyroid bed. So one possible explanation for this increased prevalence, of which we favor, includes the increased sensitivity and specificity of SPECT CT imaging. The SPECT CT imaging that we employed aids in the identification of microscopic thyroid tissue when compared to traditional thyroid scintigraphy and other imaging modalities, because it combines both metabolic functional data using iodine, which helps localize the presence of thyroid tissue being taken up by thyroid tissue, as well as combining it with cross-sectional imaging in the form of CT to help more precisely localize exactly what we're looking at. In the past, using planar imaging alone would have resulted in reduced sensitivity compared to using SPECT CT imaging. Also, by combining cross-sectional imaging with functional imaging rather than cross-sectional imaging alone, we're better able to localize exactly where the thyroid tissue may be. It's also possible that in the process of radioactive ablation, we may have stimulated small foci of functioning thyroid tissue along the route of migration, resulting in increased detectable iodine uptake at the thyroglossal tract. Nevertheless, we still believe that even though we may have increased functioning thyroid tissue, is still pre-existing thyroid tissue that existed along this route of migration. Another further consideration is that the foci may instead represent non-thyroidal tissue uptake in structures that express enhanced sodium iodide symport activity. For example, inflammation, trauma, infection. All this may result in increased uptake. And as we all know, just because there's uptake on the planar images or SPECT CT images does not 100% mean that it's thyroid tissue. Loss of tissue and loss of processes may result in increased uptake. One limitation of our study that should be noted is that the study population consisted only of patients diagnosed and treated for differentiated thyroid cancer. So as a result, the prevalence reported in this article may not be representative of the general population. These are our references, and thank you for listening in.